Well, hello and welcome back to another case in which ultrasound impacted the clinical care of a patient. My name is Scott Glazier. I am one of the ultrasound fellows here at Massachusetts General Hospital. And this case today was sent to me by one of our residents, Dr. John Eichen. The case was a 30-year-old who came in as a trauma after falling on the train tracks here in Boston. Came in tachycardic, though normal tensive, and after a primary and secondary survey was completed, a fast exam was done. First, you see here is the right upper quadrant, and you can see a couple things. First, you find as you begin this clip that there is this anechoic finding between the liver and the kidney, and this in Morrison's pouch is free fluid. So already we have a positive finding. Sometimes people get confused when they see the gallbladder right here and think this is free fluid, but a couple clues here. First, you do see a well-defined wall or border around this structure, and you do see part of the portal triad, which should be clues that this is not free fluid, but this part here is indeed free fluid. Again, to show what free fluid here looks like compared to a normal fast on the right side, here is a right upper quadrant here, which is normal compared to this one over here. And so after the right upper quadrant, the team then moved the probe to the left, and here is what they found. A couple things to learn from this image. First, maybe it's a little too superficial or shallow and that their depth could be improved. But you see here the diaphragm, and we've learned that fluid in a trauma patient on the left, whether it's a splenic injury or other types of trauma, the most sensitive finding is between the spleen and the diaphragm. And on this image, you can see the spleen here, you can see the diaphragm come in and out, and then you have this heterogeneous material and anechoic finding here. This is free fluid, and this is concerning for clotted blood. And we know it's clotted blood because A, it's more hyperechoic than the texture of the spleen. It's heterogeneous, and it is surrounded by anechoic finding here. You do see a little squirt that comes in during this clip, which is concerning for active extravasation. This is not Gerota's fascia. This is not fat from the kidney because this is the spleno-diaphragmatic space, and this is not the space between the spleen and the kidney. Again, when you compare this to a normal fast exam on the left upper quadrant here, you can see the diaphragm and you can see the spleen and the nice interface here compared to here where you find the diaphragm over here, the spleen, and the heterogeneous material right here. And this is also what clotted blood can look like. This is a right upper quadrant from a different patient, but again brings to your attention that you look at the texture of the liver, the kidney, and then you see this finding here that is clearly different than the other two and is concerning for clotted blood. There are 4 clips here. First, I want you to take a look at this. This is, again, illustrating that when you do look in a fast exam, it's important to see the spleno-diaphragmatic space. There is anechoic finding here concerning for fluid, and then there is this hyperechoic heterogeneous material that comes in that is concerning for blood. This is not the stomach in this clip, though that can be confused for other fast exams, and this is an artifact. This is indeed blood based on the CT scan from this patient. This again illustrates that it's important with the fast exam, especially on the left, that in addition to looking at the spleno-diaphragmatic space, you really would need to look at the tip of the spleen too, because if you didn't, you'd miss that little anechoic finding here of fluid. There it is again. This is the normal clip that we talked about, and then this is our patient, again illustrating where the diaphragm is, the blood clot here, and the active blood bleeding right there. And this too can be active bleeding. It's just as time goes on, it starts to clot and become more heterogeneous. So to go over the anatomy real quick, since I think it's important, and a lot of residents have come up to me and they've tried to ask, well, how does fluid, when you have injury to the spleen, which was the case in our patient, who eventually was found to have a grade 4 splenic lac, get to the right side of the abdomen? Well, there's a couple ways it can happen. First, you can have an injury to the spleen from which it will travel over here. The stomach is seen in this picture here, but when a patient is lying supine, it does flatten out a little bit and allows for more of a conduit to get towards the liver. You can also have injury to the gastrosplenic ligament here, which will then allow fluid to travel through the lesser sac, through the epiploic foramen, which is also known as the foramen of Winslow, into the right side of the abdomen. We also talk about how the interface between the spleen and diaphragm is very sensitive for fluid, and the reason for that is because of the splenocollateral ligament right here, which is why you see it more superior as opposed to inferior on our FAST exam. So take-home points I want you guys to remember. First, blood on the FAST exam. It can look anechoic, but it can also look heterogeneous like it did in our patient. In addition, it's really important that you fan and that you look at both the spleno-diaphragmatic space and also close to the kidney to make sure that you are optimizing your views in order to make sure that there is no fluid. And to remember the anatomy, that though you may have a splenic injury like our patient, that you could get fluid onto the right side of the abdomen. So, hope this case was helpful. As always, please email us at mghedus@gmail.com and let us know if you have any thoughts about this case. Thank you very much.